Hi, my name is Miguel Mendoza. I'm studying medicine. I'm a semester, and in this video I talk about paternally inherited IGF2 mutation and growth restriction. Definition: IGF2 was expressed in the early embryonic and fetal development. IGF2 is present in the circulation and can be detected in plasma. The highest circulating levels of IGF2 in fetal circulation.
Which must be coming from our father, and also expression of few genes which must be coming from our mother, right? And this process is called genomic imprinting. So let's talk about it. So here it is, the role of insulator gene in the major scale is genomic imprinting. Why? Because this genomic imprinting is simply a phenomena in which the expression of certain genes is determined by whether the gene is inherited from the female or the male parent. That means there are some genes that are present in our body that can only be expressed from the paternal chromosome, and obviously there are some genes that can only be expressed from our maternal chromosome, that cannot be extracted from both the chromosomes, right? So these are some specific genes. For example, gene IGF2 is an imprinted gene, and those genes which are under control of genomic imprinting are called imprinted genes. So as an example, IGF2, which is an imprinted gene, can expressed only from the paternal chromosome. On the other hand, H19 can only be expressed from the maternal chromosome. For example, if you look at this picture, this picture will be clear to you that, for example, this maternal one, which is H19. So here we can see that two of the genes HGF2. So let me change the color. Here it is HGF2, which need to be expressed from paternal chromosome, but this chromosome in the maternal chromosome. But remember, all of our cells will have same number of chromosome and same type of genes. So both of them, maternal as well as paternal chromosome, are having both these genes, IGF2 as well as H19. So let's talk about this maternal one. So here it is, maternal chromosome is having gene IGF2 as well as H19. Okay, but what they are having separated using an insulator sequence, and obviously there are some proteins that will go and sit onto this insulator to make a wall. So this protein is called CTCF, which is making a wall like structure. Okay, so we are having two genes, IGF2 here, H19 here. Okay, now here what we can see that activators, so there are some activator proteins which are present downstream here in this maternal chromosome. Now these activators are providing this protein. So this activator will come and it can sit onto this promoter, right? So imagine if this insulator is if the insulator is not present there, then what will happen? This activator can come and sit onto this promoter, or it may come to sit onto this promoter. So both of the possibilities can be there, and as a result of this activator attachment to the promoter, it will recruit polymerase, and the transcription of the gene will occur, right? So as a result, here what we can see, the activator will come and sit onto this promoter only. Why? Due to the presence of the insulator, this activator region cannot be attached to this promoter of IGF2. So as a result, it is ensuring that in this case only this H19 gene will be expressed, but not IGF2, because of the presence of this insulator and insulator binding protein. It will block the attachment of this enhancer sequence or activator protein with the promoter of IGF2, because what we know here, only we need the expression of H19 from the maternal chromosome, and this IGF2 must be expressed from the paternal one. So what we need here, we need to block the expression of this gene, and we can do this using this insulator sequence with the help of insulator binding proteins. Okay, similarly, if we look at the parental chromosome, so we are having again both these things, IGF2 as well as H19. Again we are having insulator at the middle. Now what we are having again an enhancer further downstream of both the genes. So this can bind with both the sequence promoter of H19 as well as promoter of IGF2, but there is an insulator which is blocking this to happen. It is methylated. As this insulator is methylated and bound with some proteins, this enhancer region cannot be bring close together with this part. Why? Remember here, so here what we can see, this insulator is free. Just look at in this case, in the previous case the insulator is bound with protein CTCF, so that the bending, remember this enhancer need to be very close to the promoter sequence for recruiting the polymerase, right? Because we need to bring them. For bringing, we need to bend this DNA. Due to the presence of this protein, it cannot be bended so far that it can bind with the promoter of IGF2. That's why the expression of IGF2 is never there. But it can easily bend onto the promoter of H19. That's why the H19 expression is always on. But in this case, we don't have any protein which is bound with the insulated region, so bending can be easier. But on the other hand, what we are having, methylation. Now the methylation can be obtained in this H19 gene. Even if this enhancer can be bound here, it can easily be bound here, it can easily be bound here, both this case. But due to the methylation that is present in H19 gene, even if the enhancer bound, even if this activator protein bound with this promoter sequence, it won't recruit polymerase. So the expression of H19 gene will be halted, and only the expression of IGF2 will be on, because there is no methylation present in this IGF2. So it ensures that this paternal chromosome will express this IGF2 but not H19. Similarly, in this maternal chromosome can only express H19 but not IGF2. So these are the process of blocking or of having what we can say gender based or sex based expression of some genes, which is very very important, because we need some traits coming from our father only, we need some traits coming from our mother only. Okay, so that is a very very important part.
Application in medicine. The phenotype affect only family members who have inherited the variant through paternal transmission, and finding that is considered with the maternal imprinting status of IGF2. The several growth restriction in affected family members suggests that IGF2 affects postnatal growth in addition to prenatal growth.
Prader-Willi syndrome is a genetic disorder that, in infancy, causes poor feeding and low muscle tone, and then in childhood causes overeating, intellectual disability, and low sex hormones. Prader-Willi syndrome happens when a handful of genes on chromosome 15 aren't transcribed into messenger RNA and therefore aren't expressed. Among these are SNRPN, which stands for small nuclear ribonucleoprotein polypeptide N, and a cluster of SNORNAs, which stands for small nucleolar RNAs. And these genes all have protein products that modify other RNAs. Now, normally the copies of the genes contributed by the mother, or maternally derived genes, to this region are silenced or turned off, and only the genes from dad, or paternally derived genes, get expressed. This special genetic process is called imprinting, where only one copy of the gene gets expressed, not both. And this differs from most genes in the genome, where both the maternal and the paternal copies are expressed. So those maternal copies are imprinted and therefore silenced. And this silencing of the maternal copies is an epigenetic process. In the word epigenetic, epi means outside of, and genetic refers to the DNA sequences of A's, C's, G's, and T's. So epigenetic silencing of a gene means turning it off while keeping the DNA sequence itself the same. The Prader-Willi genes get turned off when methyl groups get attached to the DNA, a process that happens way back when the mother was making an egg. Even after fertilization of the egg and all of the cell divisions it takes to make a person, the epigenetic mark remains, kind of like a reminder to keep those maternally derived copies of the genes turned off. Unfortunately, though, this means that if paternal copies of the genes don't get expressed, then there aren't any backup copies being expressed, and so no copies of the genes get expressed. And this is exactly what happens in Prader-Willi syndrome. Now, there are a few ways these paternal genes wouldn't be expressed. The most common one is a deletion on the paternal gene spanning the Prader-Willi region. A lot of deletions also include a nearby gene called OCA2, which codes for a pigment that gives color to the eyes, the hair, and the skin. So Prader-Willi patients with deletions that encompass OCA2 can have a light complexion. Now, a second way is called maternal uniparental disomy, which means two chromosomes from one parent, the mother. If both copies of chromosome 15 were derived from the mother, that means all the Prader-Willi genes are methylated and therefore silenced, since there aren't any unsilenced paternal genes. This can happen when the primary oocyte in the female, which eventually becomes an egg cell, undergoes non-disjunction during meiosis I, which ultimately results in an egg cell with 2 maternal chromosomes. And after combining with a sperm cell, you get a zygote with 3 copies, called trisomy 15. Since trisomy 15 isn't compatible with life, the fetus only survives if they lose 1 copy of the chromosome in the early embryo, called trisomy rescue. So if it's the paternal chromosome 15 that's lost, the result is maternal uniparental disomy 15. Alright, a third way to get Prader-Willi syndrome is a mutation in the imprinting center, which is a sequence of DNA near the Prader-Willi genes that directs imprinting via sex-specific methylation. If that paternal imprinting center gets mutated, then that region gets methylated, and those genes get turned off, meaning that both the maternal and the paternal genes get silenced. Sometimes, though, that methylation happens on the paternal chromosome even when there's no imprinting center defect, and that's called an epimutation. Normally, the paternal grandmother's methylation, after being passed to the father, would be erased when the father's making sperm. But in epimutations, it doesn't get erased, and so it gets passed on. Finally, there might be translocation, which is when 2 chromosomes swap material. Translocations can disrupt snRNP and move the small nucleolar RNA genes away from their imprinting center, causing them to get methylated and turned off. Usually, newborns with Prader-Willi syndrome have low muscle tone, which makes them extremely floppy. They also have a poor sucking reflex, which makes it hard for them to take milk, and can have failure to thrive, which means that they have poor weight gain. By late infancy, eating gets better, but then turns into overeating because the child feels hungry even with a full stomach, which is a problem caused by dysfunction of the hypothalamus. Without restricting access to food, a child with Prader-Willi syndrome can become morbidly obese, which can lead to other conditions like type 2 diabetes and obstructive sleep apnea. As a result of the mutation, children often have distinct physical features, like almond-shaped eyes, a narrow forehead, and a thin upper lip, as well as small hands and feet. They can also have developmental delay and a low IQ. In Prader-Willi syndrome, the hypothalamus has issues secreting gonadotropin-releasing hormone and growth hormone-releasing hormone, which can cause decreased sex hormone levels and short stature, respectively. Now, with Prader-Willi syndrome, there's a mutation in the Prader-Willi gene region on the paternal chromosome. One thing to be aware of, though, is that a mutation to the same region of genes on the maternal chromosome can affect a gene called UBE3A, which is only expressed on the maternal chromosome and imprinted on the paternal chromosome. If this happens, it causes Angelman syndrome, which results in severe intellectual disability, seizures, and ataxia. This region, therefore, is more accurately called the Prader-Willi Angelman region, because paternal mutations lead to Prader-Willi syndrome, and maternal mutations lead to Angelman syndrome. Diagnosis of Prader-Willi is done by looking for evidence of a genetic mutation linked to Prader-Willi. And as for treatment or management, it's often necessary to restrict the amount of food that a child with Prader-Willi eats. And this is often done by locking the refrigerator and cupboards. In addition, giving growth hormone can help improve overall height and lean body mass. Unfortunately, though, there's no medicine or surgery that's worked to control the overeating. Alright, as a quick recap, Prader-Willi syndrome's an imprinting disorder, where mutations only on the paternal copy of chromosome 15 causes the disease. In infancy, it causes low muscle tone and poor feeding. And then in childhood, it causes overeating, obesity, inadequate genital development, and low IQ. Thanks for watching. You can help support us by donating on Patreon, subscribing.
Pros and cons. The pros are they still can live. They have therapy to increase muscle mass. They can grow by eating a lot. The cons are there is no treatment available, can cause death intrauterine growth restriction, and cause Russell-Silver syndrome.
In this video, we'll discuss insulin-like growth factor 1. IGF-1 is produced mainly from the liver by the action of growth hormone produced by pituitary. It's a peripheral target hormone for growth hormone. GH induces circulating IGF-1 and its production from different tissues, mainly from liver. Because GH is a major determinant of IGF-1 synthesis, a reduced synthesis or abnormal action of growth hormone due to any cause leads to a decreased insulin-like growth factor 1. It's a potent growth and differentiation factor, and it circulates bound to IGF-1 binding proteins. Growth hormone stimulates epiphyseal pre-chondrocyte differentiation. This action is indirect and mediated by a sulfation factor or insulin-like growth factor or somatomedin. What's chondrogenesis? Chondrogenesis, epiphyseal plate widens and lays down matrix at the end of the long bone. This is known as chondrogenesis. So growth hormone acting on the liver producing insulin-like growth factor 1 that acts on the bone. This is an indirect action. Its peak occurs at 16 years of age and declines to more than 80% with advancing age. IGF-1 and 2 have close structural resemblance to ovarian hormone relaxin and insulin. The growth hormone, on the other hand, resembles to prolactin and HCG, whereas this one resembles relaxin and insulin. So what are the conditions? We have lower levels of IGF-1. It is lower with sepsis, cachexia, malnutrition, because hypocaloric states are associated with GH resistance. What are the conditions where IGF-1 are high? It's high in acromegaly. What are its uses? It's approved for use in patients with GH resistant syndromes. It induces hypoglycemia and lowers the insulin resistance in insulin-dependent diabetes and controls diabetes. Number 3, in cachectic subjects, increases nitrogen retention and lowers cholesterol level. It enhances protein synthesis and are anabolic and induces bone formation and bone turnover. What are the side effects of overdose of IGF? It causes reversible hypoglycemia, hypertension, fluid retention, temporomandibular joint pain, and increased intracranial pressure. Avascular necrosis of the femoral head also reported. It inhibits the GH itself.
Issue applied in Ecuador. In Russell-Silver syndrome, in disordered characterized by slow growth before and after birth, their paternally inherited copy of the C1 region often has two female groups attached. There have been some cases with IGF2 problems. Importance of prenatal ultrasound.
Insulin-like growth factor 1 and 2, also known as IGF-1 and 2, are two ligands implicated in the development and progression of numerous forms of cancer. They mediate their effects by binding to their receptor, IGF-1R. Once active, IGF-1R can trigger the activation of the PI3 kinase AKT signaling cascade, a pathway that has been implicated in cell survival and in the prevention of apoptosis or cell death. Activation of IGF-1R can also trigger the activation of the MAP kinase signaling cascade, a pathway that has been implicated in cell proliferation and growth. Therefore, it is of no surprise that the IGF-1R signaling pathway is associated with the development of various forms of cancer due to its role in cell survival, growth, and proliferation. Increased expression of IGF-1, 2, and IGF-1R have all been correlated with the presence as well as the severity of various forms of cancer. Activation of this pathway has been correlated with resistance against well-established anti-cancer agents, suggesting the overexpression of these proteins might serve as an escape mechanism. In the case of IGF-1 and 2, genetic studies have shown that the presence of these ligands is altered and its expression and activity is elevated at the protein level for certain forms of cancer or as a response to certain conventional therapies. Such changes have been correlated with poor survival rates and resistance to chemotherapy. Research has also shown that increased circulating levels of IGF-1 and 2 positively correlate with disease severity and negatively correlate with long-term survival rates in patients with cancer. In light of extensive research linking insulin-like growth factor signaling to cancer, several approaches have been developed in an attempt to inhibit this pathway. This includes developing antibodies and tyrosine kinase inhibitors targeting IGF-1R. Such antibodies have reached advanced stages of clinical development. Alternatively, targeting IGF-1 and 2 rather than their receptor has emerged as an alternative approach to inhibit the insulin-like growth factor signaling pathway. Boehringer Ingelheim is currently developing BI836845, a monoclonal antibody which is designed to bind and to neutralize the function of both IGF-1 and 2 ligands. In preclinical models, this antibody has shown the potential to inhibit the proliferation of cells derived from various cancers. In mouse models of cancer, BI836845 has also shown the potential to inhibit tumor growth. This highlights the potential of inhibiting both IGF-1 and 2 for the treatment of cancer.
Conclusion. In conclusion, growth restriction is a fed phenotype family first generation, who have inherited the paternal transmission. Therefore, is a fed growth before and after birth, such as Russell-Silver syndrome. Thank you.
Hi, welcome to Physionic, where we learn the body from the macro to the micro. If that's something you think you'd be interested in, then consider subscribing. Alright guys, today's video is another subscriber question, and this subscriber question comes to us from Rational Learner, a long-time subscriber. Now, Rational Learner wants to know, how does IGF-1 or insulin growth factor 1 impact muscle protein synthesis? And you might be able to guess that it has a positive impact on muscle protein synthesis. But I'm going to give you a little bit of the mechanism, and I'm going to also illustrate another thing that it does for your muscles. So IGF-1 is a communication protein, if you want to look at it that way, that binds to a receptor, an insulin growth factor receptor on the actual muscle cell or cells in general, and then that transduces a signal, so meaning that the molecule itself does not move into the cell, but it leads to a conformational shift. So the protein that's on the other side of the cell membrane changes. It kind of moves its conformation, the way that it's structured. And when it does that, that leads the cell to be signaled, or to transduce a signal, to move the signal on down through a cascade. Now that cascade eventually leads to an impact on a protein that I've mentioned a few times before, named mTOR, or mammalian target of rapamycin. It's also named other things at this point, but mammalian target of rapamycin is what's most well known for. So mTOR then further transduces on particular other proteins like 4-EBP, I think that's 4-eukaryotic binding protein, and an initiation factor which bind to our genes and lead to greater transcription. and an eventual translation of that mRNA into actual proteins to then be used and integrated into our musculature. But not only does IGF-1 have an impact on that, it also has an impact on degradation. And it does that through the phosphorylation of a particular protein by the name of FOXO. So FOXO is a transcription factor that moves into the nucleus when it's not phosphorylated and then activates particular genes, which would then lead to greater degradation. So IGF-1 has the opposite effect by phosphorylating, adding a phosphate group to that FOXO protein, which then leads to that FOXO protein, now phosphorylated, cannot enter the nucleus. And therefore, if it's blocked from entering the nucleus, then it can't act on those genes, and therefore you don't get an increase in the degradatory gene pathway, or one of the degradatory gene pathways. So IGF-1 has two main ways that it can impact our muscles. It certainly increases muscle protein synthesis, but it also has an impact in muscle degradation. So hopefully that answers the question for you, Rational Learner, and anybody else that was interested. And with that said, I hope that I have the absolute pleasure of speaking with you in the next one. Have a good one, guys. Bye.